don't, because we sent it. Not only do we send, I send it to you personally, I send it through my laptop. If you haven't got a link, please tell us. Yeah, today morning I did not remind you because I was busy with a couple of things. So please don't do that. All right, we are about to start with the first slide. It's Pariza, no? All right.
Good afternoon.
Good afternoon. First slide. इसके ज़रूरत है. It's in the way. All right. So we're going to deal with the most common of the three, which is ordered on a woman when she's not able to get pregnant: FSH, LH, and prolactin. And you can see that it is the brain that controls most of it, right? It's the hypothalamic hormones, and the pituitary gland play a very important role, as do the ovaries, and in the man, testes. All right. So for the man, fertility and secondary sexual characteristics are there. Similarly, with the ovaries, fertility and secondary sexual characteristics in the female. So what are hormones? Hormones are the body's chemical messengers. They're produced and released by one organ, travel through the blood vessels, and deliver the message to a target organ, causing a change. While hormones may pass many other organs on their journey, the target organ is the one that recognizes them and can interpret the signal, right? The human body produces more than 50 different hormones, including insulin, which lowers blood sugar, antidiuretic hormone, which retains water in the kidney, and cortisol, the stress hormone. But it is the reproductive hormones we are most concerned with over here. The 7 main ones are estrogen, progesterone, testosterone, luteinizing hormone, follicle stimulating hormone, human chorionic gonadotropin, and prolactin. So this is the woman's menstrual cycle, and you can see what goes up and what goes down, right? So somewhere the ovulation is somewhere on the 13th, 15th days, it happens usually. And then you've got the follicular phase, and then you've got the luteal phase towards the other 17, 18, 19 days. You've got the follicle stimulating hormone that comes up through peaks more or less at the ovulation time. You've also got a hormone called estradiol, E2. You've got the luteinizing hormone, which peaks again at ovulation. And then you've got progesterone that follows in the 19-20 day cycle. Keep this in mind. All right, so here we go. You've got the pineal pituitary glands in the brain. You've got the anterior lobe and you've got the posterior lobe, and you've got the thyroid in your neck, and you've got the parathyroid in there also. You've got the adrenal on top of the kidneys. All right. You've got the stomach, pancreas, etc., etc. And you've got the corpus luteum, which is your egg and the follicle. And the testes, you have the endocrine cells and sperm producing cells. All right, so this is your whole sexual cycle. So again, we come back to estrogen, progesterone, and testosterone. These 3 hormones are called steroids, in which cholesterol or lipid is the key component. Estrogen and progesterone are released by the ovaries and affects 2 organs. They cause the pituitary gland in the brain to slow down or increase release of FSH and LH, and they direct the uterus to thicken its linings in preparation for a potential embryo. Estrogen peaks around mid-cycle. You saw that in the last bit that we saw. Below also you have the same thing. right before ovulation, while progesterone peaks in the second half of the menstrual cycle. Testosterone, the male steroid hormone, is also produced in small amounts in the ovaries and is an essential female sex hormone that boosts the libido. Okay. Okay. Please, will you shut up? Will you shut up? I'm sorry, this dog is giving us a lot of trouble today. Okay, so now we've got the follicular and the luteal phase in this diagram. So you can see the starting of the progesterone. You can see the estrogen. You've got the peri-ovulatory phase and the perimenstrual phase. Oh, so this baby, I don't want you. Sorry guys, I don't know what's the matter with this dog, but we have to bear with it. And you can see on the right hand side, you can see the same graph. You've got the follicular phase and you've got the luteal phase. In the follicular phase, you can see estradiol E2 and the luteinizing hormone LH. In the luteal phase, you've got progesterone and the follicle stimulating hormone. If you will give me 2 minutes, guys, I will hush her up. I'm so sorry. Where we deal with FSH, LH and HCG. These hormones are referred to as gonadotropins. FSH and LH are produced by the pituitary gland and control the action of the ovaries and testes in man. These hormones also cause the ovaries to release estrogen, mature eggs and ovulate. LH released in a surge is the hormone that most ovulation predictor kits detect. Another gonadotropin HCG is the hormone that most pregnancy tests detect. This hormone is actually produced by developing an embryo that implants in the uterine lining. Somebody join me. Just a second, guys. Nazdeen. All right. Okay, let's go back to the slide. Sorry for these interruptions. I don't know what's the matter with my dog today. Okay. Okay. So yeah, we were talking of FSH, LH and HCG. Alright, so you know that HCG is something that we test for in pregnancy in urine as well as in blood. Alright, now take a look at this little graphic representation. The FSH hormone, follicular phase. See where the peak is. You've got the first 14 days and you've got the next 14 days. You've got the follicular phase and you have the luteal phase. And here you have a picture of the brain. You've got the hypothalamus and you've got the release of the hormones as and when needed depending on the phase of the woman's periodic cycle. All right, and you've got yes, you can see the effect of the hypothalamus, the anterior pituitary, which releases LH, and you've got the effect of estrogen coming through. You've got immune cells also, and you also have estrogen inhibins, and you've got the cytokines also coming. So a little bit of immunology comes into place there. And in the anterior pituitary, you also have the release of FSH, which is important in bone resorption. Then you come to prolactin. The hormone is produced by the pituitary gland and its primary function is to stimulate milk production. But prolactin also affects ovulation and menstruation, and much of the prolactin in the blood can cause infertility by inhibiting FSH and GRH, gonadotropin releasing hormone GnRH, and blocking ovulation from being triggered. Prolactin is one of the reasons why women usually don't ovulate or conceive while breastfeeding. All right, so this becomes important, especially if she's not being able to conceive. And usually prolactin is looked at, and if prolactin is high, doctors will immediately give the treatment to bring it down so that ovulation occurs. Function: each of the body's hormones has a unique function, and all are necessary at the right time and in the right amounts for a successful conception and pregnancy. In fact, many infertility treatments work by adding artificial hormones or blocking natural hormone production to achieve the right balance. And so this is done by the gynac, and they will be able to guide the patient as to what is needed. For instance, injections of human menopausal gonadotropin, HMG, example, Pergonal, and HCG can increase the body's levels of FSH and LH. So definitely the woman will have to be in the gynec's care, and all these hormones have to be monitored accordingly. So fertility problems can occur when the target organ, the ovaries or the uterus, doesn't properly recognize or respond to the hormones' messages. Sometimes this happens because of a physical interference such as endometriosis, ovarian cysts, scars and tumors. In this case, surgically removing the obstruction may also restore the fertility. And sometimes fertility problems can occur when there are disruptions involving other parameters, parts of the body, or the production of hormones. For instance, too much or too little cholesterol may affect steroid hormone production and conception. Also, when the thyroid gland doesn't produce enough thyroid hormone. Okay, so everything is correlated. If there's a problem at conception, all these hormones are monitored by the doctor. So here we go, you've got endometriosis, you've got the fallopian tube, and you can see something is not right. There are adhesions, and you've got the uterus next door. And you have the woman who is in pain, and she usually takes a hot water bottle here on her stomach to ease the pain. Okay? Take a look. So these can be rectified by surgical procedures. Other factors that can affect sterility: sex hormones can be affected by weight gain or obesity. Fat leads to increased levels of circulating estrogens, which can alter a woman's ability to ovulate. This may be reduced, or there may be irregular ovulation. On the other hand, drastic dieting may lower estrogen levels to the point that there is not enough estrogen for ovulation to occur. So too much fat is bad, as is a person going on a diet and getting rid of the excess weight. Understanding the interaction of the reproductive hormones is an essential to understanding reproduction, as knowing the basics of male and female anatomy. Okay? So all that is also studied by your doctors. Okay, we come to FSH, follicle stimulating hormone. Is a hormone found in humans and other animals. It is synthesized and secreted by the gonadotrophs of the anterior pituitary gland. FSH regulates the development, growth, and pubertal maturation and reproductive processes of the body. FSH and luteinizing hormone LH act as synergistically in reproduction. So they both have to act together have to get the maximum advantage to the woman. Specifically, an increase in FSH secretion by anterior pituitary causes ovulation. The structure: FSH is a glycoprotein. Each monomeric unit is a protein molecule with a sugar attached to it. Two of these make the full function of the protein. Its structural similarity to those of LH, TSH, and HCG is gene controlled. So here we've got the fluctuation of gonadotropin levels in relation to FSH and LH. Then you've got fluctuations of ovarian hormone levels in relation to estrogen and progesterone. Ovarian cycle is there in front of you, the primary, the growing follicle, and so on. You know, the ovulation usually occurs around the 14th day, and then you have the luteal phase. And of course, the menstrual cycle, the uterine cycle is given to you below. Activity in both males and females, FSH stimulates the maturation of the germ cells. In males, FSH induces Sertoli cells to secrete inhibin and stimulate the formation of Sertoli type junction. It's called the zonular occludens. In females, FSH initiates follicular growth, specifically affecting granulosa cells. With a concomitant rise in inhibin B, FSH levels then decline in the late follicular stage. This seems to be the critical in selecting only the most advanced follicle to proceed to ovulation. At the end of luteal phase, there is a slight rise in FSH that seems to be of importance to start the next ovulatory cycle. Like its partner, LH, FSH releases at the pituitary gland is controlled by pulses of gonadotropin releasing hormone GnRH. Those pulses in turn are subject to estrogen feedback from the gonads. So you can see how one is related to the other. So here we go. The pictures are there to show you. Take a look. All right. So the effects in females. FSH, the growth, stimulates the growth and recruitment of immature ovarian follicles in the ovary. In early antral follicle, FSH is the major survival factor that rescues the small antral follicles, 2 to 5 millimeters in diameter for humans. For apostaxis, programmed death of somatic cells of the follicle and oocytes. In the luteal follicle stage, so remember now this is luteal follicle stage, transition period, the serum levels of progesterone and estrogen, primarily estradiol, decrease and no longer suppress the release of FSH. Consequently, FSH peaks at about day 3 of the female cycle, and that's the reason why they order this test on that day. The doctor tells the patient to go and order that on that particular day. The cohort of small antral follicles is normally sufficient in number to produce enough inhibin B to lower FSH serum levels. Alright. Effect in males, FSH stimulates primary spermatocytes to undergo the first division of meiosis to form secondary spermatocytes. FSH enhances the production of androgen-related protein by the Sertoli cells of the testes by binding to FSH receptors, the basolateral membranes, and is critical for the initiation of spermatogenesis. So here again, now you have the male part, the sperm coming into play. Measurement. Follicle stimulating hormone is typically measured in the early follicular phase of the menstrual cycle, typically day 3 to 5 counted from the last menstruation. At this time, the levels of estradiol and progesterone are the lowest point of the menstrual cycle. FSH levels in time is often called basal FSH levels to distinguish it from increased levels when approaching ovulation. So here we go. You have the FSH at ovulation, you have the luteinizing hormone, and you have the estradiol. High FSH levels. The most common reason for high serum FSH concentration is in the female who is undergoing or has recently undergone menopause. High levels of follicle stimulating hormone indicates that the normal restricting feedback from the gonad is absent, leading to unrestricted pituitary FSH production. And high FSH levels occur during, if high FSH levels occur during the reproductive years, it is abnormal. Caution with high FSH levels include premature menopause, also known as premature ovarian failure, poor ovarian reserve, also known as premature ovarian aging, gonadotropal dysgenesis, Turner syndrome, castration, etc. Elevation of FSH receptor levels has been detected in endothelia or tumor vasculature in a very wide range of solid tumors. Okay. So here you have menopause, and you've got the women having hot flushes. She likes to sit in the refrigerator, or sometimes they say menopause made me do it. There's a book here. So menopause, let's see, this is nice. Menopause is a fact of life, and it can make the beginning of an exciting new time chapter in a woman's life, says board certified OBGYN Stephen Goldberg. Another cartoon up here. Mood swings caused by menopause aren't helped by suggestions. If you feel like shouting, just close your eyes and count to 10. That's what the husband is telling her, and she's about to strike a little vessel on his head. Again, something very similar, follicle stimulating hormone and its cycle in the ovarian. So you've got ovulation, intercycle variability, and what is average is in the blue line. Take a look at it. So you've got next maturation, marking, etc. Marking starts for the next cycle. Right, so follow the lines. Alright. Low FSH levels. Diminished secretion of FSH can result in failure of gonadal function, hypogonadism as it's called. This condition is typically manifested in males as failure in production of normal number of sperm. In females, cessation of reproductive cycle is commonly observed. Conditions with very low FSH secretions are polycystic ovarian syndrome, Kalman syndrome, and hypothalamic suppression. You can study the diagram in the middle, all right? Then you've got LH, the luteinizing hormone, also known as lutropin or sometimes lutrofin, is a hormone produced by the anterior pituitary gland. In females, an acute rise of LH surge as it's called, triggers ovulation and development of corpus luteum. In males, where LH has also been called the interstitial cell stimulating hormone, ICSH, stimulates the labile cell production of testosterone. It acts synergistically with FSH. So again, you have the LH cycle in the woman's periodic 28 days. All right. Activity, both male and female LH is essential for reproduction. In females, LH supports thicker cells in the ovary that provides androgens and hormonal precursors for estradiol production. At the time of menstruation, FSH initiates follicular growth, specifically affecting granulosa cells. With the rise in estrogen, LH receptors are also expressed for maturing follicle, which causes to produce more estradiol. Eventually, when the follicle has fully matured, a spike in estrogen stimulates a positive feedback loop in cells and releases LH from the anterior pituitary, which lasts for 24 to 48 hours. You can't read the last part. ऊपर नीचे करो. All right. So again, you've got the ovary, you've got the theca cells, you've got the egg, the follicle, ovarian follicle, and you've got the theca cells as a three-dimensional electron microscopy. All right. Continue. The LH surge triggers ovulation, thereby not only releasing the egg from the follicle, but also initiating conversion of the residual follicle into corpus luteum, that in turn produces progesterone to prepare the endometrium for a positive implantation. This part is important. LH is necessary to maintain luteal function for the first 2 weeks of the menstrual cycle. If pregnancy occurs, LH levels will decrease and luteal follicle function will instead be maintained by the action of HCG hormone, a hormone similar to LH but secreted from the new placenta. In male, LH acts upon lymphatic cells of the testes and is responsible for the production of testosterone, an androgen that exerts both endocrine function activity and intratesticular activity on spermatogenesis. Okay. Now this is your mitotic divisions of the germ cell in relation to the sperms. All right, so you've got mitotic division, you've got spermatogonal stem cell, you've got mitotic divisions, 2n, 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 primary, and then you've got meiosis. Of course, that is the conversion of the DNA structure. Meiosis 1, then you've got secondary spermatocytes, meiosis 2, early spermatid, and differentiation of the steroli cells, which provide nutrient, and you've got the sperm cells. Then you've got the primary follicles, the primordial follicle. This is your corpus luteum. All right. So you've got the male and the female on either side. Normal levels. LH levels are normally low during childhood, and in women, and it's high after menopause. As LH is secreted as pulses, it is necessary to follow its concentration over a sufficient period of time to get a proper information about its blood level. During the reproductive years, typical levels are between 1 to 20 IU. Physiological high LH levels are seen during LH surge. Typically, they last for 48 hours, predicting ovulation. The detection of a spur surge in releasing the luteinizing hormone indicates impending ovulation. LH can be detected by urinary ovulation predictor kits. You got them. OPK, also the LH kit. They are performed typically daily around the time of ovulatory cycle and may be expected. A conversion from a negative to a positive reading would suggest that the ovulation is about to occur within 24 to 48 hours, giving the woman 2 days to engage in sexual intercourse or artificial insemination with the intention of conceiving. It's important and interesting. High LH levels. Persistently high LH levels are indicative of situations where the normal restricting feedback from gonad is absent, leading to a pituitary production of both LH and FSH. While this is typical in menopause, it is abnormal in the reproductive years. There, it may be a sign of premature menopause. So you've got gonadal dysgenesis, Turner syndrome, castration, and so on. Deficient LS activity. Diminished secretion of LH can result in failure of gonadal function, hypogonadism. This condition is typically manifest in males as failure in production of number of sperm. In females, amenorrhea is commonly observed. Conditions of very low LH levels are situated below. You've got Kalman syndrome, hypothalamic suppression, hypopituitarism, and so on. And you can see the picture over here where the stature is also stunted in the male, in the female. Then we come to prolactin. Is a hormone released by the pituitary gland that stimulates breast development and milk production in women. There is no known normal function for prolactin in men. Prolactin is usually measured when checking for pituitary tumors and the cause of breast milk production that is not related to childbirth, galactorrhea, decreased sex drive in women, libido in men and women, impotence, infertility, irregular or no menstrual periods, amenorrhea as it's called. Normal range of prolactin, males is 2 to 18 ng per ml. Non-pregnant females 2 to 29 ng. For pregnant women is 10 to 209 ng. Normal values may vary slightly among different laboratories. Alright, so we've got inputs, examples, sucking, stress sleep. You've got the hypothalamus and okay, this is what is involved in that, okay, for the baby, if something is abnormal. About abnormal results in mean, people with following conditions may have high prolactin levels: chest wall trauma or irritation, hypothalamic disease, hypothyroidism, kidney disease, pituitary tumor that makes prolactin, other pituitary tumors and diseases. Certain medications can also raise prolactin levels, including antidepressants, butyrophenones, estrogens, and H2 blockers. Okay, and that was the last one. There's quite a bit that we've thrown at you, but just if you would just revise it in your mind, what is the menstrual cycle, what happens when, in how many days, and what hormones are important. That should be good enough. Especially if there is somebody having problems conceiving, then your gynec is the best person to advise you. She is going to ask for hormone studies, and depending on the results, she will give the treatment. Or if the person is into IVF, then these hormones become important because they have to know when to do the fertilization. I wish Chile was here because they deal with IVF quite a bit. Mm. I should have insisted that she comes in. Yes, Nazneen, you made it? Nazneen, can you hear me?
Yes, ma'am. Good afternoon, ma'am.
Good. So you made it in time. You made
Sorry,
it.
ma'am.
You made it in time.
Sorry, ma'am. I'm late today. It will not happen again.
No, that's okay. But you're still at the old job, or you've gone on to the new job now?
Sorry, ma'am.
I said, are you with the new job or with the old job?
I have just applied, ma'am. I have just 1 minute. I have just got the offer letter, ma'am.
Oh, great.
On the and in between to check the efficiency, they were calling for some consultant rounds also.
Hmm.
So they are applying for CAP. So initial making the website ready, the CAP data which we have to put for the laboratory organization data. All that I have finished making the master list and everything I have
Until yeah.
finished. Now we have to go into technical.